Hey all, let's talk about disorders of the small bowel and the colon. Inflammatory bowel disease or IBD. This is an umbrella term that describes two conditions, Crohn's disease and ulcerative colitis. Both of them are idiopathic in nature. We don't really know why they happen, and we study them together because there is a lot of similarity in their symptoms, the treatment, and the diagnosis. The most accurate diagnosis for inflammatory bowel disease is colonoscopy, and sometimes a barium study can also be done. In Crohn's disease, sometimes there is so much edema and inflammation that it leads to fibrosis and narrowing of the lumen of the bowel. And that's why when you do a barium study, how do you do that? You give the patient a barium meal and then take an x-ray. You often see a sign called the string sign, as you can see in this picture. And this happens because of the fibrosis and inflammation caused by Crohn's disease. Now, when you think of an inflammatory bowel disease, the name has the word bowel in it, so you assume that the symptoms will be limited to the intestine. However, in IBD, you have both intestinal and extraintestinal symptoms which exist beyond the digestive system. Now let's begin with the intestinal symptoms. They are diarrhea, weight loss, abdominal pain, bleeding, fever. Here you need to note that the bleeding is not necessarily gross. Okay, you might have occult or microscopic bleeding which the patient cannot see. And in severe cases, the bleeding can be gross, called hematochezia. Now the extraintestinal symptoms, they affect different parts of the body. In the eyes, they cause episcleritis, scleritis, and iritis. In the liver and the gallbladder, they can cause a condition called Sclerosing Cholangitis, which presents with which symptom? Pruritus. In the skin, IBD can cause pyoderma gangrenosum and erythema nodosum. Now we are going to discuss all of these extraintestinal symptoms in detail in the coming slides. Now the first extraintestinal manifestation that we're gonna study about is episcleritis. Now when you look at your eye, you see the white of the eye and you call it sclera. However, there is a transparent covering on top of the white of the eye called the episclera. When there is inflammation which is limited to the episclera, it's called episcleritis. However, when the inflammation is present in the layer below the episclera, that is the sclera, then it's called scleritis. Now, the most common ocular manifestation of IBD is episcleritis, and it's often confused with pink eye or scleritis. You can have redness at one point, or the redness can be present all over the eye. If the redness is at one point, which is more common, it often helps to distinguish between episcleritis and scleritis. Now, the flare of this condition in the eye, it is parallel to the flare of IBD. So if a person suddenly starts having more diarrhea, abdominal pain, maybe even bleeding in the stool, then he or she may also have episcleritis parallel to that, because that's an IBD flare. If you treat IBD, then this condition also resolves and it does not damage the eye. However, the next condition, scleritis, affects the sclera and it's pretty harmful. It's an autoimmune reaction of the body, and it leads to a lot of pain because the sclera becomes severely inflamed and red, and it's an emergency. It can damage the eye. So the next extraintestinal manifestation of IBD that we're going to discuss is sclerosing cholangitis. We all know that bile is produced in the liver and is stored in the gallbladder. Remember, bile is not produced in the gallbladder. In sclerosing cholangitis, these bile ducts, they get inflamed and there is narrowing and scarring of these bile ducts, which prevents the bile from reaching the gallbladder. Hence, the bile pigments, they overflow and enter the circulation, hence leading to pruritus. That's basic science. You can see this greenish colored liver specimen, and the color is green because these bile ducts get damaged and then there is leaking of bile pigments into the liver, which gives it this color. So now let's talk a bit about the skin manifestations of IBD. So as you can see these two pictures, we are talking about pyoderma gangrenosum and erythema nodosum. Now both of these conditions are very painful and it's characteristic. Erythema nodosum causes these reddish discolorations and swellings in the extremities, whereas pyoderma gangrenosum is more like, in this slide we are going to compare Crohn's disease and ulcerative colitis. Okay, so first, Crohn's disease. When the kind of lesions that you see are usually skip lesions, the lesions are not present continuously. They are present at some parts and there's a patch of normal tissue followed by another lesion. That's why they're called skip lesions. Involves the entire GI tract. They can happen anywhere from the mouth to the anus. The lesions are transmural. If this is the wall of the bowel segment that's affected by Crohn's disease, the lesion will be transmural. It'll exist along the entire thickness of the wall, and that's why they're deep ulcerations. They can be linear or stellate, and there is rectal sparing. The rectum is usually not involved in Crohn's disease. Now let's see how ulcerative colitis is different. The lesions are usually superficial. They are mucosal ulcerations. The lesions are really shallow. If this is the wall of the colon, the lesions only affect this part, the mucosa. Erythema is present. There's lots of redness. The friable ulcers are present. When you look at it, we'll show you the endoscopic view of ulcerative colitis. You will see there's a lot of redness and the lesions seem like ulcers. First, the rectum is involved almost always, and then the rest of the colon. As the name suggests, it's ulcerative colitis. The condition is limited to the colon and actually begins from the rectum, whereas Crohn's disease, the rectum is always spared. Next, the kind of lesions seen on biopsy are granulomatous lesions, whereas here you see crypt abscesses are seen. Crypt architecture is altered with shortened branches. Palpable abdominal mass, probably due to fistula. Now, as you know, the ulcers in Crohn's disease are transmural, so that increases the chance for the formation of a fistula with a neighboring structure. Like there can be a fistula between the bowel and the bladder. There can be a fistula between the bowel segment and the vagina, or between two intestinal segments, because the inflammation crosses the wall and reaches here, and below that is another intestine, so it can easily reach the other wall, and then there's a connection between the two bowel segments or two structures, which is a fistula, and that can lead to a palpable abdominal mass. Whereas ulcerative colitis, it presents with a condition called tenesmus because it starts from the rectum. So there is an urge to defecate, but you cannot defecate. There's bloody diarrhea, sometimes there can be hematochezia, urgency. Smoking is a risk factor of Crohn's disease. Smoking actually helps relieve ulcerative colitis. Okay, so this is like one of the rare medical conditions where smoking actually provides relief, but that does not mean that you keep smoking, because it may alleviate your ulcerative colitis, but you might end up developing COPD, emphysema, or lung cancer. Now when you look at the intestine with endoscopy, you will see a cobblestone appearance. Have you gone to a park? You can see that the park floor, it has many big stones which are all cemented together, which is called a cobblestone path, and that's how the intestine looks on endoscopy. Whereas this is limited to the large bowel. Strictures and fissulas are present, no skip lesion, anal involvement or fissula. So there are no skip lesions, there is no anal involvement or fissula. Rectum is involved, but anus is not involved. Here the anus is also involved. Complications like diarrhea, calcium oxalate crystals, kidney stones, cholesterol gallstones all occur with Crohn's disease. Now diarrhea occurs here also, but no calcium oxalate crystals, which actually form kidney stones, then cholesterol gallstones occur in Crohn's disease. Increased risk of colon cancer up to 8 to 10 years. So every time a person is diagnosed with ulcerative colitis, you have to repeat colonoscopy, known as a screening colonoscopy for colon cancer, because they have a higher risk of colon cancer, which is actually less with Crohn's disease. Now what is the characteristic antibody that's seen in Crohn's disease? It's ASCA or anti-Saccharomyces cerevisiae antibody. The characteristic antibody of ulcerative colitis is ANCA. So here is a diagram where you can see the difference between a normal intestine and an intestinal segment affected by Crohn's disease. You can see the internal surface and the normal wall. Here you can see there's a lot of fat straddling or fat wrapping. Usually happens in all conditions in which there is an ulcer or a fissure or a perforation, even seen in diverticulitis. The wall is thickened. Look at the wall here and the size of the lumen. You can see the wall becomes thickened, and then there's a fissure. It can actually extend all the way and form a fissula with another intestinal segment or another organ. And this is the cobblestoning that I was talking about. Cobblestone like intestinal surface. You can see all these lesions, these skip lesions, they make the intestinal surface look like a cobblestone. So this is the endoscopic view of Crohn's disease affecting a segment of the bowel. Here you can see all the lesions. You can see the fatty lesions here, and you can see that the lesion is not continuous. You have lesion here, then you have some space, then another lesion here. So these are the lesions in Crohn's disease, and it looks like now this is the endoscopic appearance of ulcerative colitis. What you see here is that there's more redness, and there's more, that's called erythema. There's more ulcers which look friable. So this is normal intestinal mucosa, then this is slight inflammation, moderate inflammation, and severe inflammation looks so red and so friable. So that's the appearance of ulcerative colitis. You will not see any spared areas here. You will see areas which are normal, and then you will see the areas which are affected, because there are no skip lesions in ulcerative colitis. So the whole thing will be like this. That's why there's gross bleeding in this condition, because it causes shallow ulcers which stay limited to the mucosa, and there's a lot of inflammation, a lot of erythema, and that causes a lot of bleeding. Crohn's disease can lead to malabsorption. Why? Because the intestine from the mouth to the anus is affected. That means Crohn's disease affects the small intestine, and the small intestine is responsible for absorption of many fat soluble vitamins like vitamin K, vitamin E, vitamin D, vitamin A, vitamin B12, which is reabsorbed in the stomach after it binds to casein intrinsic factor in the stomach and then is absorbed in the small intestine. So Crohn's disease can affect the absorption of all of these. Why? Because it can affect any part of the intestine. Anti-Saccharomyces cerevisiae antibodies are seen, and anti-neutrophil cytoplasmic antibodies are seen in ulcerative colitis. Prothrombin time may be prolonged due to vitamin K malabsorption. So a person may have anemia because iron is not absorbed, plus there is bleeding. Then they may have increased bleeding because vitamin K is not absorbed properly. That's why prothrombin time is prolonged. Another interesting condition seen along with Crohn's disease is calcium oxalate stones in the kidneys. So this happens because fat is malabsorbed in the small intestine, let's say the ileocecal junction, and it causes reduced calcium absorption and increased absorption of oxalate, and that leads to formation of calcium oxalate stones. So that's why it can be treated by giving cholestyramine to treat calcium oxalate stones. So this is a picture showing the anatomic distribution of Crohn's disease and ulcerative colitis. You can see ulcerative colitis is affecting the entire colon. There are no skip lesions. You can see it affects the whole thing uniformly till wherever it affects and nowhere else. Crohn's disease is affecting some part of the right ascending colon, some part of the left ascending colon, some part of the transverse colon, some part of the small intestine. So Crohn's disease is not very selective in which part it affects. It can affect anywhere. Ulcerative colitis, the name suggests. So this picture is like a summary of the gross endoscopic and histologic view of normal Crohn's disease and ulcerative colitis. You can see in Crohn's disease there's fat wrapping and cobblestoning, fissure and thickened wall. In ulcerative colitis there is mucosal polyps called pseudopolyps. Surviving mucosa actually forms those pseudopolyps. You have lesions, and wherever there is a little bit of surviving mucosa, little patch, it looks like a polyp. There is ulceration, loss of haustra. Intestines have haustra. This is haustra. You can see here it becomes like a lead pipe. There is loss of this haustra, and here the haustra is present, whereas the lumen becomes much smaller. The lumen is so big here, the lumen is so tiny here. You can see cobblestoning beautifully here. You can see the pseudopolyps here, and then you can see a normal beautiful intestinal lumen here. It's so big. Here also the size is maintained. Here you can see the lumen disease is usually really the more severe of the inflammatory bowel diseases, because it can affect anywhere, and because of that, since it affects the small intestine, you have many malabsorption conditions, and you have calcium oxalate stones which are not there with ulcerative colitis. So these are the locations where Crohn's disease occurs, with the frequency of its occurrence mentioned. Most frequently it occurs in the distal ileum. Then next is the right colon. So the ileocecal junction is like the favorite spot for Crohn's disease to occur. It can also occur in the small intestine alone, 5%, the gastroduodenal junction, 5%, and the colon alone in also a big percentage. Now this slide is about the complications of Crohn's disease. The first one is about stenosis, which happens in 50% of people. Here you can see the intestinal wall has become so thick and the lumen has become so narrow. So this is stenosis at the ileocecal or ileocecal junction. This one is again an example of stenosis. The rest of the ileum will be distended because whatever food is here, it's not able to enter this part. Sometimes you have a fistula, like I told you. There is a lesion here and it's distended too, and then this is the transmural lesion is extending and reaching the sigmoid colon. So now there's a connection between these two. So it's a fistula, occurs in 20% cases. In 30% cases, you'll just have inflammation. The lumen is kind of still patent. This is a radiographic image of a fistula. Now this is a beautiful diagram talking about all the extraintestinal manifestations of Crohn's disease. You can see the aphthous ulcers, stomatitis in the mouth, the steatosis and sclerosing cholangitis, gallstones in the biliary tract, spondylitis, sacroiliitis, peripheral arthritis, because there is malabsorption of calcium, vitamin D, circulation, phlebitis, skin erythema nodosum, pyoderma gangrenosum, both kidneys. There are stones, hydronephrosis, because sometimes stones get lodged in the ureter or the renal pelvis, fistula, and UTI is also seen, because you know whenever there is stasis of urine, you can have UTI. The kidneys are affected, eyes, episcleritis, uveitis. So these are all the extraintestinal manifestations of Crohn's
Some of the
disease,
diagnostic techniques
used for Crohn's disease and ulcerative colitis. A very important instrument used is a flexible sigmoidoscope. You can see how the scope works in this slide. The doctor actually connects it to a plug point and has a scope in his hand and a video monitor which the scope is connected to, and then it has a tube-like structure which enters the colon, and then it has a camera, and then you can see the image of that camera on this video monitor. So you have an instrument channel, irrigation channel, a video camera lens, and a light. You need light because it's absolutely dark in there. Cross section of the colon and rectum. So this is how it enters. Sigmoidoscope in position in the colon. This is the tip of the sigmoidoscope. That's how it looks. So you can actually irrigate and clean the intestine with it. You can take video, photographs, light it up so that you can actually see those photographs, and an instrument channel if you want to take a biopsy. So that's how it looks. Okay, now since sigmoidoscope will not work in case of Crohn's disease, which also affects the ileocecal junction a lot, apart from the small intestine or the gastroduodenal junction, for which we'll actually use upper endoscope, which is called a esophago-gastroduodenoscopy. So that is different. But here, if you want to check this area, the ileocecal junction, you need you need to do a colonoscopy, and you use a colonoscope for that. Now it is the same actually, like sigmoidoscope has a video camera lens, irrigation section, light, and an instrument channel, but it is longer and it can reach the ileocecal junction, and that's how it looks. The scope view. This slide is about how you can use the instrument channel to take a biopsy of the colonic mucosa. This instrument channel is being used to insert biopsy forceps and then pinch a part of the colon and take a biopsy sample out. They're really sharp so that they can take out a sample, and then you can view that under a microscope, a specialized histopathologist will view that. And in case of Crohn's disease, you'll find granulomatous inflammation. In case of ulcerative colitis, you'll find crypt abscesses. You'll find that the crypts are distorted, loss of structure of crypt and loss of branch structure. So that's how you'll make the diagnosis when the endoscopic view is not very clear. You cannot get a definitive diagnosis. There's no clear cobblestoning or skip lesions being seen. So now we come to the treatment of inflammatory bowel disease. This is very important because the treatment is based on the severity of Crohn's disease, and the treatment is not constant. It's going to vary with the course of the disease as the person responds to them. The severity of the disease impacts the use of anti-inflammatory drugs and risk of future complications. Extent of disease is relevant in the determination of what kind of therapy will be most efficacious. Example, a topical or targeted therapy. In case of a mild disease, you can try a topical therapy, especially in ulcerative colitis, which is limited to, let's say, the rectum. But when it's very extensive, so you want to make sure that you need targeted therapy. The therapy that you give the patient treats the active disease and also maintains the remission, so that once the flare dies down, after that the new flare comes in after a long interval of time. Treatment should suppress the active inflammatory disease medically and help to conserve the small bowel. Surgery is always the last option. Drugs for inflammatory bowel disease. Now this is a therapeutic pyramid which has drugs from the least aggressive at the bottom to the most aggressive at the top of the pyramid. So you start with agents like topical ASA, which are mesalamine and sulfasalazine, and then you go all the way up to infliximab, which is Remicade, and the new kid on the block, to experimental therapies which have not even appeared on the block. They're like a Hail Mary at the end when nothing is working, and even if that doesn't work, then you do surgery. But surgery is not curative in case of Crohn's disease. So treatment of Crohn's disease. Experimental therapies are the last resort. After many studies that 5 ASAs are often ineffective. Sulfasalazine and mesalamine are not effective in Crohn's disease. Colonoscopy with biopsy is done for acute exacerbations. ASA derivatives like mesalamine is used both in ulcerative colitis and Crohn's disease, but not very helpful in Crohn's disease. Sulfasalazine has more side effects due to the presence of a sulfa group. Sulfa is ineffective in small bowel disorders, whereas mesalamine is effective in both large and small bowel disorders. That's why it's definitely the better agent, but it's more effective in ulcerative colitis than Crohn's disease. What do you do when there is an acute exacerbation of inflammatory bowel disease? Specifically talking about Crohn's disease. If it's a mild disease, then we use steroids like budesonide, less systemic side effects, and it's used to treat right-sided exacerbations of the colon, that is right ascending colon and terminal ileum. So what we should remember, that buddy is right, budesonide is on the right-sided colon. Methylprednisone and hydrocortisone are used for left-sided exacerbations of the colon. So prednisone and hydrocortisone, or prednisone and cortisone, go left. Buddy is right. By this you will remember that the other agent, methylprednisone and hydrocortisone, are for left. Pentasa is the name of mesalamine used in Crohn's disease. Asacol and Rovasa are topical mesalamine used in ulcerative colitis. Pentasa, mesalamine for Crohn's. Asacol and Rovasa are topical mesalamine for ulcerative colitis. Now, when it's a moderate case of Crohn's disease, person has fever, weight loss, anemia, abdominal pain, nausea, vomiting, and diarrhea, but not necessarily bloody diarrhea because the blood is occult. we give active steroids. But for maintenance, azathioprine and 6-mercaptopurine or methotrexate are used. For remission, after that, anti-TNF antibodies, anti-TNF alpha are now the most popular treatment for Crohn's. Remember, infliximab is always a third-line agent after refractory ulcerative colitis or fistula-forming Crohn's disease. Don't mark that as the first answer. Severe to fulminant Crohn's disease. High fever, vomiting, rebound tenderness, obstruction, fistula. If there is all of this, then you need to give IV steroids or anti-TNF agents. Better choice and possible surgery. However, surgery is the last resort because, after surgery there is always a risk of recurrence. Okay, so now we come to how to treat fistulas that form in Crohn's disease. Anti-TNF alpha is the best agent for fistulas. Infliximab, sertolizumab, adalimumab, all these are agents. If anti-TNF fails, we use a new agent called natalizumab, a monoclonal antibody to integrin alpha 4 on leukocytes. So you start with TNF alpha inhibitors, Inflixi, sertoli and adalimumab. If this fails, then you go to Natalie. These sound like girls' names: Inflixi, sertoli, adali, and then comes Natalie, which is a monoclonal antibody to integrin alpha 4 on leukocytes. So TNF can cause PML, so you have to check JC virus antibodies first, and it has other side effects: arthralgia, increased risk of several cancers like melanoma, non-melanoma skin cancer, non-Hodgkin lymphoma, reactivation of TB, septic shock can occur. Surgery is curative for ulcerative colitis but not Crohn's. Now remember, PML stands for progressive multifocal leukoencephalopathy. It's a demyelinating disease of the central nervous system which infects the oligodendrocytes and is caused by JC virus, which is a human polyoma virus. For perianal disease, we always give an antibiotic like ciprofloxacin and metronidazole. If there is fistula or disease refractory to other agents, give infliximab, and surgery is not very effective due to high recurrence at the site of anastomosis. Now, treatment of ulcerative colitis also depends on the severity of disease. If it's mild, only 4 bowel movements per day, minimal bleeding, normal labs, gives mesalamine or sulfasalazine. It can cause reversible infertility in men and leukopenia because of the sulfapyridine group. That's why mesalamine is preferred. If there is moderate ulcerative colitis, then there is 4 to 6 bowel movements a day. That's moderate. So for active disease, you give prednisone. For remission, you give budesonide, which is another steroid. But for long-term maintenance, you give steroid-sparing agents. When the patient goes into remission, you give azathioprine, 6-mercaptopurine, but they are related with drug-related pancreatitis. Now, effects don't start before 3 months. Hence, when you start these azathioprine, 6-mercaptopurine, steroid-sparing agents, you need to overlap them with steroid treatment for the first 3 months, and then you stop the steroids. Now, severe ulcerative colitis, more than 6 bowel movements a day, bleeding, fever, tachycardia, and ECR is raised. That means inflammation is there, anemia. So for acute exacerbations that fail steroids, and for maintenance, if even azathioprine and 6-mercaptopurine fail or are contraindicated, give IV steroids followed by anti-TNF alpha, infliximab, adalimumab, and golimumab. However, surgery is curative in most cases of ulcerative colitis. In 60% cases, patients need surgery after 5 years of UC due to refractory symptoms of severe disease. Now, these are images which show the kinds of surgeries done in inflammatory bowel disease. The first is surgery where the colon and the rectum are removed, which will probably happen in ulcerative colitis, and that's called proctocolectomy. Colon and rectum removed. And then there's an ileostomy, and there's an ileostomy bag. So here you're removing the whole colon and the rectum. There's a cut made here. The only thing left is the ileum now, and that is you make an ileostomy called the Brook
Next
ileostomy
is,
and put an ileostomy back. If there is an obstruction at the ileocecal junction and a fissure between ileum and sigmoid colon, then you cut this part off, you repair the fissure, and you form an ileocolonic anastomosis. You remove the cecum. Now here, see here, the cecum and the ileum are resected and an anastomosis is formed. Resection of cecum and ileum with ileocolonic anastomosis. Now, resection of cecum and ileum, ileorectal anastomosis. So in this case, the colon is also removed, the cecum is also removed, and the ileum is also removed. Okay, the colon is removed and the cecum is removed, and you form ileum is connected to the rectum. This is an ileorectal anastomosis. So for example, it's Crohn's or ulcerative colitis affecting the whole colon. So you just remove the whole thing and connect the ileum directly to the rectum. So that's all about inflammatory bowel disease. I hope you understood this condition better after watching this video. If you like it, please subscribe. Click the subscribe button below, and thank you.